आपको कोई तो रास्ते चल रहा पूरा लाइट कम अच्छी भीतर ना पूरा लाइट कम अच्छी भीतर पूरा ना तो बुझे दीजिए बात जो नहीं ठीक है प्रोब्लेम अच्छी ठीक है तो मत खाली यूट्यूब लिंक टा पठे दो पठे दीचो पठे तो तुमको एटा सार आसले पिंधे बुझ पाइल प्रोफेसर आसले एटा अच्छा
ମାନେ ତାଙ୍କ ଭିଡିଓଟା କଟି ଯିବା କଥା हेलो हाँ सेटा मैडम हाँ
hardware infection subsides and then put in. So these are important facets we want you to consider. Now again, I've been discussing with industry a big way on the designing of revision implants. It's a huge issue when you need to revise these knees with those size 1 and size 1.5 and 2 configurations, and you have the kind of offsets which will get across when we move ahead. So this, there was no choice of an articulating spacer. In this case, we went in with a static spacer, taking out those components. Now, when you try to use a distal femur replacement process, is LPS or Edler or whatever you want to use, the problem again is the same. How do you match the size? That's a very big issue for a replacement prosthesis. That's a minimum size that you have on, right? The same issue gets across when you have to use metaphyseal sleeves if you have to move on, because the minimum sleeve size is also big for them. So it's, as I say, in North India, we say call the word as jugad. So it's the parameter that you have to work across, shuffling between those lines and see what is the least amount of a compromise you achieve to make these patients walking. So when this was taken out, we went across with the revision lesion system, but mainly cemented out here because we wanted to use antibiotic bone cements to get on, because all said and done, we are retaining the distal fragment of the femur. So I wanted to move across and use antibiotic cement, so huge one, into the revision systems. So this was still okay. She was happy, she was walking, and I was very happy. I'm the blessed guy. But then she was after my life for the opposite side. Very good question. Now, these are all convex femurs. So using a longer stem would hit on the anterior cortex. Look at the picture out there. Had I used any longer, I would have perforated the anterior cortex. And I'll get on with this point that you have for the opposite side. The very nice point to be gone through. We will discuss that. So till this stage, she was doing absolutely fine. She went across and asked me a remedy for the other side also, because that had failed and was not allowing her to walk. So, lock this side. Any role of robotics in this extra articular deformity?
कुछ नहीं तो ठाकुर
Mhm.
सेपरेट तो पेशेंट जीवन पेशेंट जीवन असले के गुंचे
Very good.
मत लिंक टा कर दिए मैं ताको दे दी
Okay. Now, one of the ways to look at prevent rotation, use unicortical plate. Anything different, Vijay, that you think through? Yeah.
हेलो नमस्कार हाँ हाँ
Should be good enough, but there's no harm in keeping a unicortical part, just one or two shooting screws, in case you are rotationally unstable. I agree to you, that should be just a backup. Yeah, so with the same part, we moved across. Now the points I want to cover up, and that's where, Doc, your question comes across. Now, in order to equalize, because you have anterior bowing, at the moment you want to use these rods, you have to use offsets. When you want to use offsets and translate it further, if you see there are offset couplers, and we are designing the small size offset couplers, but not available as of now in the industry. The moment you put up offset coupler, you just chop off the anterior femoral cortex. You see a picture out there? That's the place which is required to put these anterior couplers. So in very short size females, using the smaller size of the implants available and translating to manage your flexion extension gaps, you have to play a lot with those systems. We had to use the burrs to just create a space, because that's what it would get onto. So if you have to translate those femurs, you require offset couplers. You require offset couplers, you are already playing with very small sizes. Whether you want to translate 2 millimeter or 4 millimeter, but 4 millimeter would just take off the anterior cortex. So the amount of translation is limited, not because of the technology, but because of the designing of instrumentation and implants. So in order to balance these gaps, you require offset stems. There is a coronal blowing, which Dr. Naik was talking about. You have to have a mismatch. And again, you have to size the AP and the ML. So my point time again is smaller size North Indian or Indian females with anterior bowing of the femur. How do you manage those things? So look at this first X-ray out here. The moment you use an offset coupler, see almost you're off the anterior cortex, but you balance your flexion extension gaps. For the tibia side, we did exactly as you were saying. I wanted to rob those areas. I did not require a fibular osteotomy, just was a minimal swing off. We packed up the bone, whatever we could harvest from the notch to fill up those parts, and this bone healed. But there were a lot of learnings in this case. We cannot use any more longer rods to support in. This is the maximum length you can capture across. There was a good metaphyseal support. I had also the S-ROM noils with me on the table, but the metaphyseal sleeves, the smallest were also biggest for this patient. So sleeves would not fit in. So many times you require a huge deal of inventory on the table. What should be a fallback plan? Point A, point B, point C. And the point was well captured up. In this case, once we put up this capture, there was no need of an additional rotational component, but I would agree to him, those kind of backups need to be there on the table. So this is what she was post this, and we were the lucky people to move through. Now, the learnings out of this to a second case, we spoke yesterday about the stiff knees. There was a whole session on stiff knees and how to manage the stiff knees. This lady, 65-year female, known diabetic, 12 years, had some infection in left leg for which fasciotomy was done in 2000. Then 3 years later, her left TKR was done. She was doing fine as per history. 7 years later, she developed a PJI. In 2010, 2 attempts to Debrima was done, and all of them failed. Then the surgeon in 2011 ultimately did the removal of prosthesis, and compression device for arthrodesis was attempted. She presented to us in 2013 at that stage with failed arthrodesis, moderate pain, and demand for revision. Her infective markers were all normal. We tried on aspiration to ESR CRP. This is what the picture was. Down there, you have the fasciotomy scar that she had on. Up there, there was Chanle compression device probably used up for this patient for arthrodesis, which did not function up. She was a stiff knee with hardly 10 degrees of a jog of motion. And this was the picture on the X-ray. A failed arthrodesis conversion to TKR. We had a discussion yesterday on these topics. Now, look at the position of the patella baha that you have through. You have a contracted quadriceps because arthrodesis is attempted on. So here, the biggest issue is the expectation to the patient, because you have an adherent quadriceps, you have a contracted quadriceps, you have a patella baha, you have a stiff knee, You have a compromised skin on the top. So the formulation of flaps is also tougher. So any special points you would like to keep in mind if you think of moving ahead and doing this revision? Yes. Plus, in these cases, there are a lot adherent actually with the back of the tibia. So those positions are extremely important. Yeah, 7 years, 6 years.
Other than this, that is CS1, I've seen patients with CS1 having infection of their implants. So some part of infection.
Yeah, they were. So what Dr. Deva is trying to say is any remote site of infection which can be a source. We worked up that was not there, but as it entered out, we will move past. Is the fact that you need to cover on these are the options that you have to keep in mind. So leave it as such or attempt a re-arthrodesis in this case. You can do a single stage revision or you can move back in 2 stages. First, get off, do a debris again, put up a spacer and then come back into it. These are the options that have to be in your mind. I was going to work with both C and D in mind. I'll move inside and see, but if everything is stable, I'll go back and revise in the single go. The challenges are, number one is the exposure. As we were talking yesterday about the role of tibial tubercle osteotomy and extensile exposures, talking in terms of quadriceps snip. What are kind of exposures? Because simple exposure normally would not bail you out. You have to be mentally ready with the backup plans of your extensile exposures. What is the kind of quality of bone that you're going to get through? Because any bone that has gone through arthrodesis initially, you're going to find a non-viable sclerotic areas out there. Knee bending. She already has a jog of motion with a contracted quadriceps, so the expectation has to be toned out. Any chances of re-expectation and expectations.
Hello.
So in this case, we just did a snip and we could circumvent that. Still, she has the patella baha as you see out there, but could manage with 60, 70 degrees of knee bending.
Hello.
So
Hello.
these are
Hello.
again the systems where
Hello.
exposures are the
Hello.
number one, the most important part. Getting onto a
Hello.
viable piece of bone is point 2.
Hello.
Point 3 is the zone 2 and zone 3 fixation. You need to be very particular to these
Hello.
things. And she still has a date doing well. Third case, 58-year female index surgery for primary ONE bilateral. I did her bilateral. She was the time, I think it was a launch of Attune knees at that stage. I did a Attune bilateral TCAR on her and she was doing fabulous. She was doing absolutely fine till around a couple of years. But then she presented to me with this picture. I was very surprised to have this kind of presentation of heteropic bone, because if you look at the past, there was nothing. She certainly presents to me 2 to 3 years later with this kind of picture out there. So we worked up for all those parameters, markers, everything was normal, and I sent her back. Okay, let's observe and let's see, because I didn't have an answer why she's developing this kind of a picture. But to my surprise, now 2 years later, she presented with this. We again thought of all rare variants. I mean, trying to work on PCR for TB and trying to hit and dry infection parameters. Everything was clear. So move back in and we try to move in. Okay, let's move in and see whether we need to have a stage 1 or a stage 2 looking inside. But we went inside. The quadriceps were ossified, as you see pictures out here. But we could get across with a simple revision system. And there was no sign of any physical infection, and 6, 7 years have passed. She's fine. But a rare part, because we never got to know what was the reason for this ossification developing 5 years post-index surgery. Why she had developed that kind of an osteolysis, because that was the first Attune revision. Because in those years, I did around 600-700 Attunes every year. So I had done a huge volume, but I never got it across in any other patient coming back to me with this. Neither I discussed with the company. They had listened to these kind of parameters. But there are certain rare parts for which you don't have an answer. But whenever you move in for these kind of cases, you should always be mentally ready to have a backup of a stage 1 with you, because you might find some focus of infection on those parameters. The last case across, talking of the failed extension, I could not find the pathology. I could not just. Nothing, nothing, sir. Everything was clear, and she was doing. If you look at her X-rays 4 years or 2 years post index surgery, she was doing absolutely fine. There was nothing. And this lady used to sit on the ground also. So she was a good, ambassador for me, because she would sit on the ground and do all activities, and suddenly you find this picture. So we could not find. We tried to work out. We sent it across to endocrinologist also, metabolic bone diseases, but could not reach to any conclusion. Before handling her for surgery, I had a lot of opinions because I was not clear what I'm going to get inside and what do I get myself geared with. Many times it's not just a surgery; it's identifying the root cause. But certain times you don't find it through. So this is a genetic female, 85 years old. Bilateral stage TKR done 17 and 18 years back. She came with progressive pain and deformity, left knee over 5 years, and right knee was still functional. So left knee was the main part. So we went across the X-rays. This is a typical aseptic loosening. We talked about the subsidence aseptic loosening. And she had a fracture of the patella, and the patella was lying in the lateral gutter. And she's 85, so you have to handle in. So just moving on from there. So the problem in this case is the osteolytic patella with fracture, the axial patella that we have through. You have a dislocated extensor mechanism lying in the lateral gutter, valgus deformity, and you also have compromised tibial and femoral bone stock, because it's not only the extensor apparatus, your tibia and femur are also compromised in this case. So in the planning, you will work a big way onto your exposures, what kind of processes or stems you are going to use through, and what to do with extensor apparatus. We don't have those options of allografts, but theoretically, if you look back, there is option of an allograft or a prosthesis or a rotating hinge you need to be keeping with you. So when we moved in, we find it as a corrective deformity. There was extensive osteolysis. And this picture you see very common with the old knees, where you have a COCR femur and the titanium tibia. So the patients don't get a revision done, the poly wears off, and then the COCR is rubbing against those titanium base plates. And what you have is a huge amount of metallosis and the tracant structure. So she had a periprosthetic patella fracture. Quadriceps mechanism was intact. So since quadriceps was intact, it's only the fracture of the patella that has to be dealt with. So your treatment modality changes. This was the picture that we saw inside. You look at the insert out there, totally worn through. Now this time the femur was rubbing on the tibia, and you have those, when you have different metals rubbing on each other, you have a metallosis and pictures like this. This is very common when we see patients coming with a very, very late presentation for revision. And because of this osteolysis, what you had is a huge amount of a bone loss on the femur and the tibia and the osteolytic patella. So this was the axial patella. At that time, Zimmer had this patella available with them for the revision. You could sew it through, and it's an augmentation patella. And on top of it, you put up a cemented implant. So for the patella, we managed her this thing, and revision for the knee was a typical using extensors on the tibia and the femur and distal blocks and augments. So this is one way to circumvent. The other way is, if the extensor apparatus is gone, you might require a rotating hinge to get across these cases. So from all these cases, what I want to bring across to you is the fact that you see a different kind of presentation when you see revisions. You see different kind of failures. Your mind has to always work in what went wrong. Equally, what kind of armamentarium or inventory we need to have as a fallback plan. So you have to ready, if the option is A, this is my plan. If the option is B, this is going to be my plan, because decision is not pre-decided in this case. If extensor apparatus is gone, the decision would have been different. So with this, a couple of take-home messages for all those who would like to put their hands into the complex revisions. Read the first line. Decisions are more important than incisions. Anybody can move back and open the knee, but what decision you're going to take is extremely important. And equally, when you saw all these cases, that simple sort of a metaphyseal fracture, stress fracture could have been managed very easily in the index surgery, but a wrong planning. That intraoperative fracture of distal femur, a wrong planning. So plan your index surgery well. There's a lot of learnings in all the cases we saw since yesterday onto the flexion extension gap imbalance. So many times I see a lot of my colleagues jumping over to emerging technologies. I'll use this, I'll use that. Your basics has to be right. Your basic ideology of flexion extension gap balancing, of your mechanical alignment of your knee, of your soft tissue balancing. If those index are right, your chances of developing a failures are way lesser. So also at the same time, with the inventory of revisions available in our country, the moment you get people with small sizes and you get females with bowing of the femur, be very clear, you're going to have tougher times. Ask for shorter stems, ask for cemented stems as a backup options. Otherwise, you're going to be perforating those cortices, or you're going to be having a troublesome time managing or balancing your flexion gap to be equal to your extension gap, because stem is going to be dictated by the way the femur is aligned. So these things are important, and also a lot of companies are now getting back in a background for coming small size offset couplers. That's a second option. So thank you so much. Thank you, Sanjeev, for giving me an opportunity to be speaking here out. So any questions, I'll be more than happy to answer. So possible is there, you have to be selective. We were working initially on those cases, but the question is, as long as now the cost is an indication. If the cost is the same, why would we not? Like we discussed the cases yesterday, we had for a live surgery. The only thing you require is a very snug fitting part. Your accuracy of cuts is there. So as long as you have a good accuracy of cuts, you have a good bone stock, you have a good sort of, now materials is not an issue. We use the same materials for the hip also. You require porous materials across with a high friction, high coefficient of friction. The moment you have those, I think uncemented is not an issue. But the question is, does uncemented give you like in a THR, an extended life portfolio? That is very questionable. Because normally it is not the interface of your femur and tibia that fails. Normally the interface between the articulating surfaces that fails in a tibia. So in a TKR, unlike a THR, so it is not that you ever get across that my femur has become loose without a reason. It is either a wrongly directed femur, wrongly positioned femur. So that is why when we were discussing yesterday, we spoke about the minimum interface of the cements in a primary TKR. So uncemented, yes, has an answer, but as of now, when we look at evidence-based medicine and the literature has not been able to really fulfill the promise it went on to, that you can give your patient a higher amount of a longevity of those implants. Yeah, thank you.
Just sleeping. We are getting ready.
ଏମିତି କହୁନାହାନ୍ତି ଏମିତି କୁହନ୍ତୁ।
So, good morning, everyone. Let's start. Acha.
হ্যালো হ্যালো যদি ন হবে এটা টেকি দেবো এদের কিছু হাতে মারিবনি বুঝলেন এদের কিছু হাত মারিবনি এইটাও টেকি দেবো শুনি এটা খালি টেকি দেবো দেবো এটা অঠা লগাইকি এটা অঠা দিয়ে দিলে অঠা লাগালে কোন এইটা লাগবে বুঝলি ହେଲା ତ ସାର୍ ଆସିଲେ ଦବା ଆଉ କିଛି ପ୍ରୋବ୍ଲେମ ନାହିଁ ତ
Good morning, everyone, and thank you to Odisha Orthopedic Association and Arthroplasty Society for inviting me. So I'm going to talk about the types of robots available, but before that, we have to understand what robot actually does, what robotics actually does. And I think I'm going to convince everybody that robotics is the future. So first of all, as the debate had started, like somebody like sir told that we were taught that TKR is a soft tissue surgery or soft tissue balancing surgery. It's not like that. TKR is all about balancing. The key word is balancing. It's not soft tissue. And bony cuts and bony alignments are very much part of that balancing. So it's a global circumferential balance which has to be achieved mechanically throughout the range of movement. And it need not be like the natural knee. Knee replacement need not be like the natural knee. It's a mechanical engineering. It's a global circumferential balancing which has to be achieved, and that in that bony cuts, bony alignment, and soft tissue dissection or soft tissue balancing is a part of it. So it's about balancing. It's not soft tissue balancing or bony alignment alone. And along with that, we have to keep in mind the alignment, because all the cemented implants. Cement characteristically can undergo only compressive loading. Cement cannot go shearing stress. So we have to keep the alignments reasonably perpendicular to the mechanical axis, the weight bearing axis, so that the cemented implants go only on a compressive loading. Now, the whole thing is that the robotics has evolved out of navigation. It was navigation which has started in 2005-06. Then patient-specific instrumentation came, and then robotic came. So robotic is an extension of navigation. There can be no robotic without a navigation. So preliminary, first thing we have to understand the navigation part, then only actually we can understand the robotic part. And as far as the precision is concerned, it has been proven beyond doubt that navigation always led to, robotic always led to better precision, but the results are multifactorial. Because just because the enhanced precision may not translate into a good, depends on the attitude of the patient, the mental makeup of the patient, the motivation of the patient. So the precision may not equally translate into patient satisfaction. So that's a different thing. But any navigation or robotics leads to better precision. Now, first of all, to understand So to understand robotic, first is what is a computer? So computer is something which allows us to planning. And what is navigation? Navigation is like in navigation, we used to put the bony landmarks, and then we used to put the jigs by hand. We used to put the jigs by hand, and there used to be rigid bodies which used to show the position of jig. Like if you are going to put the tibial jig by hand, it used to show medial condyle, it is cutting this much, lateral condyle, it is cutting this much slope you are getting, this much varus valgus you are getting. So that is navigation. The analogy of that would be a Google map, wherein you which is there in your car, and it navigates your way. Now some like sir previously told that why you need navigation. You don't need navigation if you know the way. That I don't agree with that. You always need a navigation even if you know the way. I will tell you why. And what is this simulation? simulation is something which is a step in robotic surgery, which cannot be achieved in manual surgery at all. Like simulation we get because we are doing 3D CT scans and we are simulating the implants, whether it is notching or not, and the sizes of the implant, whether it is medially overhanging, shifting, everything we can shift. And the biggest advantage is that we can quantize things. Like in manual surgery, we can talk of varus, valgus, laxity, balance. We cannot talk of 2 millimeter medial opening. We cannot talk of 3-degree varus alignment. So we cannot quantify things as we can do in navigation or in robotic. So that is the advantage as compared to manual surgery. And what is simulation? Simulation is like we can see previously what we are going to do. It is something analogy we can give with the Google map. For example, if you want to go to airport now, you want to know how much time it will take. So you know that it takes around 20 minutes, but there may be a procession which is going on and it may take around 1 hour. You may miss the flight. So Google map will show you exactly how much time at this point you are going to take to go to airport. So this is the analogy of the simulation that we achieve with navigation or robotic. And what is real time? Now, real time, this simulation in robotics we achieve with the help of 3D CT scan. Then after this 3D CT scan, we again shift to navigation on the actual surgery. We put tracker bulbs like navigation. Now, real time is how much is the gaps you are getting on the table or movement, flexion, extension, varus, valgus, how much gaps you are getting. This is analogous, something similar to the way you are using. Like even if you know the way from here to the airport, you know the way by heart, but there may be a traffic jam on that way and there may be an alternate route. So Google Map continuously shows you which is the shortest route at this time. So you need a navigation even if you know the road, because you do not know what is the traffic which is actually happening. So that is why simulation, real time mapping is needed. Like a Google Map uses real time. And what is a robot? Robot is something which, how it is different from navigation. Robot is something which can produce a change in the environment without human intervention. Like you have given the plan, with the computer assisted surgery, we have to put the jigs up, down, rotate the jigs on your own, and then it used to show in the screen 3D rotation, 4D rotation with respect to posterior condyle or with epicondyles. So in robot, it is doing on its own, and robot is an instrument which can produce a change in the environment without human intervention. The plan which has been given to it already. Analogy would be a self-driving car. Nowadays we have self-driving cars in India also, wherein the car follows the previous car. If the forward car, if the other car accelerates, this also accelerates. If that brakes, the car automatically brakes. So you don't need to put your brake on your own. And the car follows the lane and everything does it on its own. So that is something similar to our robotic. And what is this haptic feedback? Haptic feedback is like if your cutting tool is exceeding is going out of the bone, or it is going where it should not be, then it automatically stops. So that is haptic feedback. And to give it a haptic feedback analogy with the cars that are available nowadays is collision avoidance system. Like we have collision avoidance systems in car. If the car is going to collide with a divider in front, the car stops. If you are backing the car, if a child comes in back behind your car, the car stops immediately on its own. You are not braking it. So if there is a collision which is going to take in front of your the steering wheel rotates on its own. So this is something like that haptic mechanism, and that would have saved a lot of accidents that have happened in past. So what is the robotic TKA? In this, we are using precise pre-surgical planning executed every time. Pre-surgical planning is done by this simulation, which we do by 3D CT scan. There is optimal alignment. There is sub-millimetric accuracy, and there is real-time. Once we do the CT scan, as we will see in this live surgery subsequently, we do the artificial intelligence itself gives alignment, sizing, everything, and then once on the patient, we fix tracker bulbs and go into navigation, and then we take the real-time check. What is happening at 30-degree flexion? What is happening at 90-degree flexion? What is happening in varus stress, valgus stress? And then various cutting methods are there. It allows you to go for measure dissection as well as gap management. Gap management or modified gap management, both systems are there, and it allows you to change the plan during surgery. So like if you feel that the flexion gap is more, you want to, or extension gap is too loose, then you can decrease the femoral distal femoral cut. You can change the rotation during surgery. Everything can be done. And the difference from manual system is that in manual systems, once you have cut the landmarks, like you have cut the posterior condyles, the landmarks are gone. But in navigation or robotic, the landmarks are still there in the computer. So you can still use where the posterior condyle landmark used to be. So you can still change the rotation. And the benefits are, of course, precision and flexibility. Robots available as of now are QVIS, Mako, Rosa, Cori, and Velis. Now, some of these robots are active robots. Like active robots, the surgical planning is made in the laptop itself, and then it is given to the robot by means of a pen drive. And then to do the real-time mapping, we use navigation. That means we put tracker bulbs as we used to put in navigation, rigid bodies, tibial pins, femoral pins, as we'll see in the surgery. And then if you want to change the plan based on the kinematic factors, we can change it. So that is active robot. Then we have passive robots wherein they hold the surgical tool and the surgical tool is in your hand. It just prevents the deviation from the path, the chosen path that we have already discussed. And then we have passive robots wherein the robotic arm puts the jigs. Like Rosa, we will see that is a passive robot wherein it puts the jig. So basically, two robots are active robot. One is QVIS and other is Mako. Both of them use CT scan. Now, to use a haptic feedback mechanism, CT scan is must. Like in QVIS, if you are using a burr, and if you are cutting the tibia, the burr may overshoot and cut the posterior capsule also. So to prevent that, there has to be a haptic feedback mechanism. And that haptic feedback mechanism is only possible with CT-based navigations like QVIS and Mako. And then we have passive navigation like Rosa. In Rosa, basically whatever jigs we put with hand, the robotic arm comes and puts the jig. And we have Navio, which is based on navigation, wherein there is a handheld burr and handheld instrument, and the bony cuts are based on that. So this is the component. First is the main console. The main console has got, as you can see, the optical trackers. So there is a instrument which emits infrared rays, and those infrared rays are reflected by the rigid bodies, which we'll see in the surgery subsequently, how these rigid bodies are put. And then those rigid bodies are those reflected infrared rays are tracked by the optical trackers, and everything is measured in relation to the rigid bodies. So it is the relative movement which matters. And then the robotic arm, we have already given the plan of surgery based on the CT scan. So if we want to change anything based on the real time, that is what we are before the CT plan is before the surgery, like it has to be done before the surgery. And real time planning, if you want to change anything, it can be done during the surgery. And then the robotic arm, the milling system comes and does the bony preparation after the exposure. We have to do the exposure, and then it does the bony preparation. If we choose for a measure dissection technique, then first we cut the bones, and then if needed, we do the medial release or the alignment soft tissue release. If we choose for gap management technique, then we have to do some minimal medial release before bone cuts, and that minimal release is to correct a rigid varus to a correctable varus. If we follow a gap management technique, then we have to convert the rigid varus to a correctable varus by means of medial soft tissue release, and then we have to do the bony cuts. So I've gone fast because we will be seeing subsequently in the live surgery. And so basically the benefits are there is a 3D bone model in the simulation based on CT scan, and the simulated surgery, we know preemptively before the surgery it starts. We know the size of the implants, we know the placement of the implants, we know whether it is going to notch or not. We are sure that it is not going to notch. And when the robotic arm takes over, we can just sit and relax. And after the bony preparations are done, the implantation is done. So basically there is a personalization of implant. You can shift the femur up, down, you can rotate, you can choose any way you want. It's not based on the manual instruments, and there is some millimetric accuracy, and there is less blood loss because the bony canal is not breached. We do not enter the medullary canal, so that's a big advantage of decreasing blood loss, and it can be done in extra-articular fractures because we are not entering the medullary canal. And the biggest advantage is that like in manual system, we can only talk about we can talk qualitatively on the field, but here we can talk quantitatively. There is 3-degree varus, there is 2-degree varus, there is 2 millimeter medial opening in 45-degree flexion, mid flexion instability. Everything we can see on the screen by quantitatively. So that is the big advantage. This is one of the surgeries done recently with the correct alignment. So we'll discuss more in the live surgery. Any questions?
The only extra things that you require, you have to put to pin. Is there any complication involved in it? Because sometimes you can create a fracture.
So those theoretical possibilities are there. The present system uses 2 pins in femur and 2 pins in tibia.
Keep the pin inside that operating site, or you keep apart, away from it.
No, we keep the
Same
pin.
incision, you put the two-
No, away from the incision. Actually, we have to take care so that the robotic arm doesn't come and hit the pins, because the pins have again tracker bulbs. Yeah, as you will see, it has got tracker bulbs. So we have to keep it.
That they use pins, same incision, used it as a detector.
No, you can use that. Those things are, see, you can put pins anywhere, in any way you want, because all the things like measurements and everything is based on relative motion. So once the pins have been put in any place, I mean, not any place, but reasonably any place and any direction you can put so that the tracker bulbs are visible. And after that, it should not move. The pins should not move. The patient may move, table may move, the optical tracker may move, but the pins should not move, because all the measurements in real time are done with reference to the pins. If the pins get loose or rotate or something happens, then you have lost all the data. No, there is a restoration system, but I don't know how reliable it is. If pins have moved, you are in soup. You have to leave. You have to leave.
No, you have to go to conventional.
No, that's why 2 pins are there. In some systems there used to be 1 pin. So in present system there are 2 pins, and those both 2 pins are unicortical to prevent fractures.
Usually, metaphysical pins are inside the. When you use diphysial pins, then only.
No, you can put it inside incision. You can put it outside incision. It doesn't matter because you can choose to put inside the incision. After the surgery, yeah.
Momentum. Dr. Ravi Bangpatra will felicitate Dr. Suresh Kumar. Vijay Kumar.
Quick. लाइव सर्जरी का क्या स्टेटस है? इसमें नहीं चलेगा। ठीक है, चलो।
Dr. G.S. Patnaik will give a memento to Dr. Ankur Saurabh.
Sir, ଆପଣ ଛିଡ଼ା ହେଇଯାନ୍ତୁ, okay. Done. Thank you.
When is your flight?
Managing bone loss. 10 minutes. You can leave here at 12:10. Yeah, time.
Okay, at the outset, I would like to thank the Odisha Arthroplasty Association and the Odisha Orthopedic Association for having me here. And special thanks to Sanjeev, who's a dear friend. Thank you very much. Well, I'll be speaking on total knee replacement in extra-articular deformity. Well, as the technology is going on, I think I can just stop and say that all extra-articular deformity needs to be done by, by a robot or navigation. But so the causes of extra-articular deformity, sometimes, often you would have a couple of cases in a year, definitely, which would have some sort of a deformity. It would be either a post-traumatic or a previous osteotomy which has been done, rarely because of, bony deformity, because of metabolic bone disorder. Sometimes excessive bowing in itself, especially the Indian females who have a lot of tibia vara, they also would lead to an extra-articular sort of deformity. And often these are associated with stress fractures. Congenital is very, very rare. So the you need to quantify whether the deformity is in one plane or it's in, it's in only in coronal plane or it's in sagittal plane also, or sometimes there's a rotational deformity also. So that's a triplanar deformity. So you need to get, long leg x-rays for all these patients and both AP lateral and sometimes CT scan also. So the dictum is always and always get a long standing view. So as you see in the short view, you're not able to see the deformity, but if you see the whole view, so there is a deformity. There was, I think, there's a deformity in the femur there. It was not in the normal small X-ray seen. And you need to do a thorough, radiographic evaluation. You need to measure all this, mechanical axis deviation, the lateral distal femoral angle, the medial tibial, proximal tibial angle, the joint line convergence, and everything needs to be calculated when you are planning to do these cases. And the most important thing as far as the total knee replacement in these patients is to consider how do you evaluate the deformity. So it's not only the magnitude of the deformity which is important, but the other thing which is important is whether it is close to the knee or away from the knee, because that makes all, your decision making is based on that. So deformities which are away from the knee, so means closer to the ankle or the hip, they have minimal effect on the knee. Right, so you can very well, it's easy to take care of them. However, deformities which are closer to the knee, these are difficult deformities. There you might have to do an osteotomy, concomitant or early osteotomy, and you need to really do a thorough preoperative planning for these patients. And this was beautifully demonstrated by by an article by Wolf, who mentioned that, who found that, if a deformity of 20 degrees there, if it's closer to the knee, it causes a lot of malalignment as compared to the same deformity occurring closer to the hip, where the degree of malalignment at knee is not that much. So, similar, I think the same thing. And we have already discussed the key principles. You need to have your mechanical axis passing through the knee, through the center of the knee. The joint line has to be in an anatomical position, that means perpendicular. And so how do you correct an extra-articular deformity? So when you are planning a knee replacement, so it can be single stage using an intra-articular correction, or it has to be an extra-articular correction by an osteotomy, which can again be in a single stage or it can be in 2 stages. So first you need to decide whether you want to correct the deformity intra-articularly or extra-articularly, right? And now how do you decide that? So this is another article by Wang. This is a very much quoted paper. I think everybody should read this. So he found a simple principle when you can correct an intra-articular deformity. So you draw a line. So suppose there's a deformity in the femur, so you draw a line from the center of the femoral head to the center of the knee, and you draw a line perpendicular to the This is for the femur, right? When the deformity is in the femur and perpendicular to the, the mechanical axis. And you see whether this line is going through the, you are compromising the collaterals or not. Suppose you are compromising the collaterals. So this is your basically distal cut of the femur, right? So in a coronal plane deformity, a line perpendicular to the mechanical axis, if it is going through the collaterals, that means you need to do an extra-articular correction, right? But if it is not going through the collaterals, if it is, your collaterals are being saved, then you can do an intra-articular correction also, right? So for example, in this this schematic diagram, you are below the collaterals, your 9 mm cut perpendicular is below the collateral. So here you can do a intra-articular correction, right? Similarly, a deformity like this, again, you draw the line, and here if you see your line perpendicular 9 mm would be, you would be compromising the collateral. So here you need to do an extra-articular correction, right? So whether you use a robot or whether you use any technology, this is the basic principle that you need to know, right? This is for the femur. Similarly, for the tibia, you draw a line along the mechanical axis of the tibia in the center, right? Along the mechanical axis. And if this line is passing through the tibial plateau, then you can do an intra-articular correction, right? However, if this line is passing away, it's not passing through the center of the anywhere in the tibial plateau, then you need to consider extra-articular correction, right? If you understand this basic thing, this would, this would take care of your planning. In terms of figures, so it is seen that a deformity around 20 degree in femur or can be corrected intra-articularly. On the other hand, tibia, the figure is around 30 degree. But you need to draw these lines and see where how the whether you're compromising the collaterals or not, right? As compared to sagittal plane, now sagittal plane deformities usually are better tolerated than coronal plane deformities. However, if the deformity in sagittal plane is more than 20 degrees, then you need to do an osteotomy. You cannot correct it just intra-articularly. Up till 20 degree, you can, but you need to be careful if it's whether the procurvatum is around 10 degrees, recurvatum should be less than 20 degrees, because if the procurvatum deformity is there, the chances of notching is much higher. And with the sagittal plane deformity, along with sometimes it has a coronal plane deformity also. So, you need to do deformity correction using a laser or a hexapod before, or an osteotomy before you are planning for a total knee replacement, right? Now, if you are, whenever you are doing an intra-articular correction, you need to be cognizant of the fact that, if it's a valgus femoral deformity, you would be cutting more on the medial side, and this can lead to MCL laxity. So, you should have constraint components also. Similarly, a varus femoral deformity, you cut more on the lateral side. However, on the lateral side, you have a lot of structures which are, compensating, because you have the bicep femoral, iliotibial tract, there are more than one structures, which are there on the lateral side. So stabilizing structures on the lateral side, whereas on the medial side, you just have one stabilizing structure, that's the MCL. So this is more forgiving. Similarly, for the valgus and the varus. Now, whenever there is a extra-articular deformity, you need to understand that it would be very difficult to pass an intramedullary rod. On the tibial side, you can do an extra-articular, you can do an extramedullary instrumentation. On the femur side, you need to have some sort of, either you do an extramedullary instrumentation, or you need to have some sort of technology, which may be a navigation or a robotic or some sort of technology, so as to do your distal cut, right? And that really helps. If navigation is not there, you may even use these handheld navigations. Persis is there, eye assist was there. These devices also help you, bail out of it. Or you may even do patient-specific instrumentation. Okay, so, to do your distal cut, right? And the results using CAS has been excellent over the years. Many authors have published in extra-articular deformity, right? And the limitation again for these deformities is if you want to correct them intra-articularly, is the collaterals. So, so you need to be cognizant of this fact. So now coming to few cases. So here, if you see this deformity here, it had a sagittal plane deformity as a coronal plane deformity also, but the sagittal plane was much more And if you see, if you draw the line, it is not, we are not, cutting the collateral. So, here we use navigation and did a knee replacement. Another deformity in which again, there was a nail in situ also. Here again, we draw the line and you see. So you have to draw this line, whether you're using navigation, robot or anything. These lines help you decide whether you need an extra-articular correction or intra-articular correction, right? The robot or technology only takes care of the thing that you're not able to pass an intramedullary rod. Okay. So here again, we used, we could not use an intermediate rod. So here we did a, patient-specific instrumentation and a total knee replacement was done. Another deformity, this was on the tibial side. And if you see here, it is passing within the within the plateau. So here, you could get away doing a intermediate rod, a single stage. So again, similarly, right? And here the patient had deformity on both sides. So on the left side, if you see, it was just barely, just away out of the tip. So here an osteotomy was done first and correction was done. Whereas on the other side, we went ahead and did it in a single stage because it was passing through the tibial plateau. Okay, so another patient in which there was a bent rod here. If you see, we are compromising the collaterals by drawing these lines. And here, similarly on this tibia also, it was way away. So this patient was, we did a two-stage. First stage, we did a osteotomy and corrected it. And this was done before COVID. The patient was away for 2 or 3 years, then came back, had united. And here we used patient-specific instrumentation and did a knee replacement. Now, nowadays, a lot of literature has come up. Previously, most people used to do in 2 stages, but now you have studies and you have techniques in which you can do it in a single stage. In the femur, on the tibial side, it's relatively simple. You can use a plate, a unique cortical plate, and put in a rod, right? Whereas on the femur side, it's a little difficult to do it in a single stage and osteotomy plus total knee replacement. However, you can, provisionally fix it with some wires or maybe use an intermediary rod. And these are techniques which have been described. I'm not going to go into detail with it, but you can do it in a single stage also. Now, with these osteotomies, the problem is that you have all the problems of non-union infection and you have additional implants there. They are technically difficult. And there is a blood loss. If you're doing it in 2 stages, you need to remove the implants. When you have to do a subsequent total knee replacement. Advantage with intra-articular correction is it's a single surgery, early rehabilitation, but you should be able to, decide preoperatively, and you should be, some sort of technology should be there with you for doing intra-articular correction, right? So to sum it up, extra-articular deformity of femur, you draw these lines, and if the line is passing distal to the collateral, do an intra-articular correction totally. If it is passing, if you're compromising the collateral or the deformity is more than 20 degrees, it's near the joint, then maybe you need to plan for a corrective osteotomy and do a total knee replacement, either in a single stage or in a 2-stage. For tibia, again, you draw this line through the center of the deformity of the tibia and see whether it's passing through the plateau or not. If it is passing through the plateau, then you can do an intra-articular correction totally. If it is not, then you have, or if the deformity is more than 30 degrees in coronal plane, it's quite near the joint, then you might have to do a osteotomy and a total knee replacement, either in a single stage or in 2 stages. So to conclude, preoperative planning is of one case where you need to do a preoperative planning. Long X-rays are these extra-articular deformities. Always and always keep constrained implants as your backup, and take assistant from technology. If you have navigation, it is good. If you don't have navigation, the patient-specific instrumentations are very cheap in India now to make. They made it by 3D model, 3D printing, and the turnover of time is around 1 to 2 weeks. So you can use those, or you can use the handheld assist navigation devices such as the iAssist. Versus 2 or 3 companies have it. And if you want to do an osteotomy, be ready for a 2-stage procedure also. I thank you for your attention. Any questions?
There are any questions? Can ask. Dr. Biplab Dolo is the next speaker.
Okay. Thank you. Thank you very much.
Thank you, Chairman, sir. Thanks for the opportunity. I am still a conventional surgeon. My hospital yet to buy a robot. They are planning it. Hopefully, we'll get it in near future.
हाँ सर ने कि टूटी की पे करके आपका अभी तक कर दिया है जेल का रेडी तो जितना भी
ठीक ठीक तो कैमरा जो है ना दैट विल शो फ्रॉम हियर आप इस तरफ आ है ना
When you drive your car, you always look for potholes. If you ignore them, you know the consequences. Similarly, in TKR also, you need to
थोड़ा
look
पीछे।
for bone loss. Unless you address them adequately, then it will affect the longevity of the implant. Bone defect usually occurs on the tibial side, but it can occur also on the femoral side, sometimes on the patellar side also. It can be content defect when there is intact peripheral rim, which will help in future support to the base plate. It may be non-content when there is no intact peripheral rim. In that case, you need to reconstruct your bone defect with the various gadgets and tools. Bone defect more commonly occur on the tibial side. In case of varus deformity, it is usually posteromedial, whereas in valgus deformity, it is usually posterolateral. Several options available in your hand when you are reconstructing bone defect. You need to identify them preoperatively with the help of orthogonal X-ray. If the defect size is small, you can increase the thickness of tibial cut, or you can reconstruct them with the help of cement augmented with screw, or you can use bone graft or metal augment. If the defect is small, peripherally located, you can increase the thickness of tibial cut. However, you can go up to 10 millimeter. If you increase more than that, then quality and quantity of cancellous bone will reduce significantly, and that may lead to shrinkage of the base plate. You can also reduce the size of the base plate and lateralize it and remove the excess bone from the medial side. If the defect size is less than 5 millimeter in depth, then you can augment it with or fill it with bone cement only. This is a 60-year-old patient who had varus deformity. We noted there was a small defect peripherally, less than 5 millimeter in depth. We augmented or filled it with bone cement only. If the defect is in between 5 to 10 millimeter, then you need to augment the bone cement along with 1 or 2 screw, which will act as a pillar. This is a 55-year-old male patient. He was our own OT technician. During surgery, we noted that there was around 8 millimeter gap below the base plate. We augmented it with cement and used 2 screw as a pillar. You need to look that this screw should not touch the base plate during surgery. This is already 8-year follow-up. Still, he is working with us. If there is large defect more than 10 millimeter involving more or less 1/3 of the condyle or tibial plateau, then you need to reconstruct the bone defect with autograft. This is 62-year-old female patient. She had large posteromedial defect. She was having varus thrust while walking, and there was a large gap posteromedially. We reconstructed it with autograft and augmented with a stem. Metal augments are also available if the patient is elderly, where you are not expecting any revision. Then also you can use metal augment. This patient had a large medial defect. After doing the tibial cut, we reshaped it, shaped it, and used an augment. The patient is doing well. Revision scenario is quite different. You need to classify. In case of revision, bone loss, you need to classify them according to AORI classification. If the defect is small, particularly in type 1 and type 2A, you can go along the primary knee replacement, but type 2B and type 3 are more challenging. Here you have 3 options in your hand. Either you can use allograft or trabecular cone or metaphyseal sleeve. If you are using allograft, if it's available, readily available in your center, then you can use it. If there is large defect, This is not my case. I took it from literature for demonstration purpose. There was large posteromedial defect. They augmented it with allograft and there was good incorporation at the end of 7 years. Trabecular cone you can use to fill the metaphyseal defect. They are highly porous. They have got osteoinductive effect. They are more physiological. And there would be more physiological weight transfer to the bone. This patient underwent revision surgery. There was a large metaphyseal defect. We used cone along with a stem and he is doing well. Metaphyseal strip, another option. They are porous coated. You do not need to use cement. They convert shear force to compressive force and encourages good host bone healing. This is our own patient. He underwent TKR around 7 years back. Then she sustained a periprosthetic fracture. We fixed it, but unfortunately she developed infection. Then we did revision surgery 2-stage. We noted there was massive bone loss both on the femoral and tibial side. On both sides, we used sleeve to fill the defect. This is another patient. She underwent bilateral TKR around 7 years back in another center. During recovery, she fell down and sustained bilateral patellar tendon avulsion. Some reconstruction was done, but that also failed. She was walking with the help of walker and brace for 7 years, but unfortunately she fell down again. This time she sustained bilateral periprosthetic fracture on the left side. It was relatively stable. We treated conservatively, but on the right side, we had to do some surgical intervention. There was large mass defect on the tibial side, and we had to replace whole distal femur using S-ROM Noel's type of prosthesis. This is a hinge type of prosthesis. Now she is walking with the help of walker and some sort of support. If there is large pothole, then if you do rash driving, there would be accident. Similarly, in case of large bone defect, if you do not adequately address them, then it's going to be a day one failure. Thank you. Thank you for your patient share.
Hello.
Now we are ready for the live surgery.
Hello.
संदीप सर थोड़ा सा ऑडियो टेक कर लीजिए बात। हाँ मैं ऑडियो
इसको थोड़ा सा ऊपर कर लो तो आपका एक्स्ट्रा नहीं आ रहा है। ये लाइट थोड़ा सा ये स्टेराइल है। हाँ बस ठीक है। हेलो हेलो
hello.
हाँ
Am I audible? I am Dr. Mahapatra here.
yes sir.
Hello,
You
sir.
are audible.
Yeah.
So can you see the screen?
No, we can't actually. Acha.
Can you see the X-ray of the patient?
Yeah, we can see it now.
Okay, so he's a 63-year-old patient with varus deformity. And if you can see the X-ray, there is a posteromedial defect. Now, let me show you the patient's clinical picture. So we have opened up the joint. Can you focus on the knee? So we have opened up the joint by medial parapatellar approach. And we have applied the trackers. Now, can see that there is lot of varus instability. Can you appreciate that?
Yeah, we can. Actually, before that, can you just tell us actually how you put that tracker? What is the...
So these are simple shange pins.
Okay.
And you can directly drill them into the bone. There is a jig there. Anmol, show me that. So you have got a jig, something like this,
Okay,
and you put this shanch pins through the tracker, over which you can apply this tracker balls. इसको एक बार ढीला कर दो.
what is the site actually? How do you prefer the site?
Okay, so it is approximately 4 fingers from the joint line. To be on the safer side, I have taken approximately
5 fingers.
so that they don't come in the way of the.
Arm, robotic arm.
That's how you put the pins first,
Okay,
and you take care that they are unicortical, because then there is chance of stress fracture if these are bicortical. We have done the planning on the software. This is our final plan. Can you show the screen there? नहीं, सामने से दिखाई. एक बार के लिए इसको घुमा दो.
वहां पे स्क्रीन नहीं उसको नहीं घुमाना है, स्क्रीन को ऐसा कर दो. हाँ बस ठीक.
Alright. Okay. So according to the preliminary plan on the CT scan, the femoral size is E, tibia is 3. We'll be cutting 7.3 millimeter from the medial tibia, medial femoral condyle distally. On the lateral tibial condyle, we'll be cutting 8.8. Similarly, posteriorly, we'll be cutting 10.6 on medial side and 8.7 on lateral side. On the tibia, on the lateral side, will and because there's a defect, so we won't be cutting anything on the medial side. So we have planned to make up that defect with screws and cement, and if required, we'll also use a stem. That's our preliminary plan, but this plan will change when we do the gap balancing.
okay. So now actually whatever actually the measurement you are getting, you are blindly believing, or just you are just comparing with your manual methods?
No. This plan which you saw, that was static plan, which is done a day before on the CT scan.
Okay, sir.
Now we have put the tracker. Now we'll check the gap in flexion and extension.
Okay.
Before that, we'll do the So there are 40 points on the femur and 40 points in the tibia, which you have to register.
The gap
The
that
software will match
planning-
these points with the CT scan images so that you get the accurate image.
There is a question.
Yes,
Shekhar,
okay.
there is a question from floor.
No, not a
No.
question. Basically, what I was saying is that the plan that we saw was based on the 3D CT. So that is a plan which has been done on the laptop. That plan has been fed to the robotic arm. Now
Yes.
that plan has to be, we need to show the machine which is the real bone, and we want to make the landmarks. So here the navigation starts.
Yes.
So this part is navigation. We are
Yes.
choosing the points, 40 points in femur, 40 points in tibia, so that the robotic arm can actually collaborate it with the real bone,
One.
the CT image with the real bone,
2,
and it
Three.
fixes the haptic
4,
feedback,
5,
feedback boundaries, wherein the
One.
burr should stop if it goes outside
2,
that.
3, 4, 5, 1, 2, 3, 4.
This is being done by a pen-shaped device,
5.
which has got tracker bulbs, same as rigid bodies. So basically,
1, 2,
no,
3,
you can put 10
4,
points. Randomly
5.
10 points with some minimum distance should be there between the points. And
One.
of course, it suggests where is the medial
2,
boundary, lateral boundary, it will
3.
suggest. And another thing is that osteophytes are not removed. So osteophytes are kept like that because while doing the CT scan, we have
5.
not removed the osteophyte. So we are not going to remove the osteophyte now.
1, 2, 3,
Hmm.
4, 5.
No, that's why real time is needed. No, that's why
1, 2, 3,
With the CT
4,
scan, with the CT scan,
5,
we've done the virtual surgery.
6,
Now we are doing the real time with the navigation. With the tracker bulbs are there, infrared rays are being
7,
emitted, and the
8,
stylus which is giving the points that also
9,
is tracker bulbs.
10.
No, no, no. We will
Okay.
not remove the osteophytes. It will burr with the osteophytes.
Yes.
With the osteophytes. Osteophytes. No, osteophytes are not removed.
Yes.
CT-based navigations, osteophytes are not removed because we have done the planning with the osteophytes. No, no, that's why final trial after final trial after final cutting real time is there.
Yes.
You can always modify.
Yes.
Okay. Sir,
So the
can you
registration-
focus the camera on the knee, on the registration part, on the knee, on the operative
Yeah,
field,
dikha do.
the bone, on the bone.
So registration for the femur has been done.
Mhm.
Now we come to the tibia. Just show us, show on the body.
So now we have to register 40 points on tibia.
Okay, go.
And the computer suggests which area 10 points you have to take, like medial, lateral,
Go.
medial.
Go.
Yeah, it will suggest the areas in which you have to take the 10 points. Those 10 points in that particular area, total 4 areas are there. Total 40 points, 10 points in each area. And those 10 points has to be minimum of 1-2 millimeters, some distance is there. Otherwise, if it is
Yes.
too close, it will not accept that.
This is not
And
tibia.
these points have to be on bone. So you have to pierce with the stylus on the bone. You have to pierce the patellar tendon. You have to pierce the soft tissues so that they reach the bone.
Defect तो ये है, ये proximal lateral दिखा रहा है.
No need. No need. You may or may not remove the meniscus before. You may or may not cut the ACL, PCL, ACL. Basically, while doing the CT scan, CT has taken into consideration only bones. It has not taken into consideration the cartilage. It has not taken into consideration that 1 millimeter or 1.3 mm thickness of cartilage. It has not taken into consideration meniscus. So, like if you are mapping over the meniscus, your stylus should pierce the meniscus and reach the bone. After that, the burr will come. It will just cut everything.
So, Dr. Santosh, we are waiting for a bit because I feel that these points are not correct. The defect is on the medial side, whereas it is showing proximal medial on the opposite side. So we'll just check with the laptop.
Screen. Achha, sir, can you ask them to focus on the screen?
Screen दिखा दो.
Actually, 2 cameras चाहिए.
So you can see the defect on the medial aspect.
Yes, sir.
And the point, but on the screen it is coming as proximal medial, which I feel is incorrect. Now, this may create problem in the cutting. So we'll just have to recheck with the laptop, with our plan.
Defect is medial.
All the change. So there was error in the plan. The proximal medial tibia was marked as proximal lateral tibia. So the computer will only show what you do. So if there is a problem in registration, that will affect your surgery. So we have just corrected that, and we are again putting the plan.
So there was a planning, there is a problem with the CT planning.
Yes.
CT planning, yeah. No,
So
CT
while you are
you have
doing
to-
the plan on the laptop,
You or your assistant.
you are pointing the proximal medial and the proximal lateral.
Before the-
The software will ask you to point the proximal lateral aspect. Now, if you put a point on the medial aspect and when it is asking for proximal medial, then the whole plan will go wrong.
Yes, we have to be very meticulous in that city planning because it follows the principle of garbage in, garbage out.
Yes.
If you make a mistake in the planning, it will affect the whole surgery.
Is it starting so? Huh? We'll have to register the femur again. No, tibia. ये तुम्हारा medial, lateral, posterior, posterior. Okay. Go. 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 एक मिनट नहीं नहीं back. Go. 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 Okay, start. So we have to do the whole registration again. 1, 2, 3, 4, 5. Yes. Yes. Go. Go. Yes. Yes. Go. 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 1. 1. 1. 2. 3. 4. 5. 1. 2. 3. 4. 5. 6.
The computer screen is
7,
suggesting the area,
8,
but you can mark randomly.
9,
It had
9,
that sequence on it.
10.
You can go this way also, this way. Minimum, there has to be a minimum gap.
Okay.
Suppose the thickness of the bone of the femur, you are putting only this side also, that will not accept. Instead of
Okay. Okay.
This is marking the root mean square error.
Come back to tibia. Yes. 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 Now it's correct. Yes. Yes. Okay, start. Go. Yes. 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 Go. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5, 6. Go. Yes. 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 Go. 1, 2, 3. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes.
Cameraman, please focus the knee.
Yes. Yes. So that completes the registration part. Now what we'll do, we'll remove the osteophytes before we do the gap check. दिखा देना.
Could you just briefly explain what is that RMSE point? Which we need to mark after every registration.
So that basically
Root mean square error.
Denotes the variation between your CT scan plan and actual thing. So if it is less than 1, that means you are quite accurate. Your registration of point matches with that with the plan which you have done on the CT scan.
Is it necessary to remove the osteophytes?
It's better because then your gap balancing will be better. So posterior osteophytes are difficult to remove, but then medial osteophytes, it's always better to remove before you do the gap balancing. Especially this patient is having huge.
And what about the meniscus and ACL?
Yes, ligaments,
PCL, especially PCL.
but meniscus, it's not necessary.
So meniscus can be kept and do you remove the PCL before the bone cuts or later
I
on?
just cut it from the aspect, the femoral aspect.
Right.
So I'll just clear the notch. That's it. Forceps. Sorry.
No, whatever you do, there is a real time is there. Like this is basically this is a new technology on the everybody is on. Some people will say removal of osteophyte imbalance.
Okay. Now focus on the screen now. Screen.
Yes.
At 90° of flexion, the flexion gap on the lateral aspect is 7, and on the medial aspect it is 4. Is it clear?
So please repeat again. So these are the gaps in flexion and extension. We see the real-time gaps in flexion and extension. This is nearly 90-degree flexion.
Yes. So I'm now focusing on lateral aspect, okay? On the lateral aspect in flexion, the gap is 7. On extension, the lateral gap is 10. Can you see that?
Yeah, true.
So on the lateral aspect, there is a mismatch
Yeah,
in flexion and extension gap.
right.
Is it clear? So what we'll do, we'll move the femur proximal, distal. So femoral shift, distal involvement way down. One more.
So
Okay. So now you can see my lateral gap in extension is 8.
Right.
Again, we'll check the flexion. So it is 7. Now what I will do, I'll just move my femur 1 millimeter anterior. Up, yes. So that becomes 8.
Right, sir. Now it is balanced.
So now it is balanced. The lateral side is balanced in both flexion and extension. Okay. Medial side, if you see, there is a contracture. It is showing 5. But we know that the patient is having so much of varus deformity. So we will have to release a bit of tissues on the medial aspect. So I think we can manage that with the soft tissue releases. Secondly, the patient is having osteophytes on the medial aspect also. We may have to do some subtraction osteotomy, and that will take care of the medial side. So in a varus knee, we'll focus just on balancing the lateral gap, both in flexion and extension.
So
Is
this
it
is
fine?
basically what the simulation is. So initially we found that there is a mismatch in flexion and extension gap on the lateral side. So we made the
Hence-
femoral component
hence.
distal to decrease the extension gap laterally, and we moved the femoral component anteriorly to increase the flexion gap laterally. No, this is a simulation. We are moving it now. It will cut. There are no holes like manual system. Now accordingly it will come.
Now we'll put the pins to
Distal
fix the
femoral cut
robo.
कम जाएगा. If we have moved the component distally, that means distal femoral cut has been decreased. If we have moved the femoral component upwards, that means the condylar cut has been increased by 1 millimeter. Yeah.
Okay.
So medial side will balance it by yeah. So this is a pin to retract the patella so that it doesn't come on the way of the burr.
Knife.
And another point which is different from navigation is that we have to fix the patient's limb with the robotic arm. Another very important component, another very important aspect is that we have to fix the femur and tibia with the robotic arm. So this is what he is doing now.
Small pins for retraction.
Now we have to fix the femur and tibia with the robotic arm.
Robo lete आओ.
So this step is different from navigation.
No, drill pe.
So if there is any movement on the bone, it should not affect our registration. So for that, we have to fix the femur and tibia with the robotic arm. There is a external fixator type of thing, sans pin on femur and tibia, and that fixes with the robotic arm. No, there is no specific point. Even for putting the rigid body is is the point of, is generalized area and then point of convenience. Oh, yeah, we have to keep
leave
in mind that the burr will come and operate. It should not come and hit the burr. And the tracker bulbs should be angled in such a way
yeah.
that they are visible to the computer. That is very important. So that visibility indicator, everything is there on the screen. Because see, the whole system is the OTS is emitting infrared rays, and that infrared rays are being reflected back by the optical trackers, the cat's eye like thing, and those has to be catched again by the OTS. So they have to be visible. So OTS has to be placed in that way. And the pins pins have to be put in such a way that do not come and with the way of the burr.
और तो नहीं करना पड़ेगा. Okay, now we'll bring the robo.
On the side of the surgeon normally.
अब इस पे focus
No,
करें.
no, opposite side is the OTS screen. Screen is opposite to the surgeon, and the robot is on the side of the surgeon.
Unfortunately, the robo got switched off, so it is taking some time to log off.
Actually, they are like it is always difficult to do the surgery outside our regular OT, especially if there is a new technology. Right, sir?
Yeah, it's okay. Here the atmosphere is quite like home.
Yeah.
It's just that unfortunately the power got switched off. So it's
Would you like to comment on the fixation of bone to the robotic arm and the haptic mechanisms that are working there? Like we have to fix the
fixation of a robot to the tibia and femur.
Yeah.
So there are two systems. Either you can fix them with pins, or we also have with these clamps. If you don't want to put pins, then you can use those clamps. Sir. Just show me the clamps. And 1 mm किया था और distal 2 down किया था. Okay. So you can use these clamps also instead of these pins. So you can fix this clamp like you can fix the clamp here on the femur, and then there's another clamp on for the tibia, and then you can use these clamps to fix the robo. थोड़ा सा कैमरा को इस तरफ कम और कम बहुत ज्यादा कर दिए. So now we are watching on the screen that the optical tracker is seeing both the femoral marker, the tibial marker, as well as the robotic marker. So all three markers are to be seen by the optical tracker.
So we are increasing the table height just for better visibility of the optical trackers, markers.
Okay. Fix. Right.
There are two additional equipments. One is foot holder, like in the desired angle of flexion extension, you can hold the foot. And there is a distractor, which is applied in the posterior part of femur, distal femur, just to distract the femur away from tibia when the burr will be cutting.
So today we are not using distractor
Okay.
because there is enough gap and we think
Okay,
that we
good.
can work without that.
Right, sir. Right, sir.
Probe. Check.
नहीं वो चेक कर रहा है सब ठीक है हाँ नहीं मतलब कोई पिन लूज तो नहीं हुआ है कोई ये तो नहीं हुआ है बिफोर बोन कटिंग हाँ
Again, rechecking the points.
वहां पर वो कैलिब्रेशन चेक करता है एक्चुअली बिफोर सर्जरी हाँ रूट मीन स्क्वायर एरर है लेस देन 1
डिस्टल किए थे ना जी पक्का अब तो निकल गए थे
slightly confused
So now the robotic arm is have started. So it's a milling tool and it's a burr based system. While it is taking the cut here, we are seeing it real time on the screen.
and it has got a continuous water irrigation system. So the first cut that the robotic arm is taking is the distal femur, and we are doing through measured resection technique. Now there is an emergency button always in the hand of the surgeon's assistant. Going wrong, but that is very unlikely, very unlikely.
So
there are
it has taken the distal cut.
You know,
now there is an
I think it's
option that if you
multiple
want to take just extension cuts, you can take the distal femoral cut and you can then take the proximal tibial cut. You can use the normal 4-in arm jig for the rotation and the posterior cuts.
No, but that
here will yeah.
Not very fast, but it is fast.
Now it is taking the anterior chamfer cut. So it will take all the 5 cuts in the femur.
So normally it cuts very fast and very smooth. It's really, the cuts are really very smooth, and it just spares the outer rim of the bone so that not to invade the soft tissues. So that outer rim has to, milling system is far smooth.
Also light hटा दो.
Okay. No, it's very smooth. Okay.
वो लाइट भी जरा उसको उधर हटा देना.
अच्छा, there is haptic feedback. What it means is that the moment burr is outside, not touching the bone, it will stop. So we had marked the points and it will stop just before those points. So there will be outer rim of bone which will be left, and that has to be removed with a nibbler. So that is purposefully, the robot leaves it purposefully so that it doesn't invade the soft tissues.
Okay, start. Stop. Go to the next cut.
So it has got a so-called 6-dimensional flexibility. The robotic arm is reorienting itself. So the posterior chamfer cut, and after that we'll do the box cut. Hmm. No, generally it is not happened. Hmm. Hmm.
करते रहो, तू करते रहो. You keep on doing.
There's a zone of, the researchers don't repeat it.
नहीं, medullary canal need not be opened. नहीं, वो हो गया होगा तब. हाँ, yeah. Medullary canal need not be opened in navigation also.
Wait. Recovery.
No, it will finish.
Manual guide.
No, it will finish all the cuts in the femur.
So the tibial spine is coming in the way. So we'll just remove that.
If you want to
So-
stop something and then jump, then you have to do something. It will keep on going.
So
If you don't want to jump anything, it will keep on going.
So the tibial eminence is coming in the way of the robotic arm. Okay, go. Back. No, let me come from there. Okay, so okay, go. That's nibbler. Go. अब ठीक है हो जाएगा. Go. Again, go. Okay. So Nibbler. हाँ हाँ ये कर सकते हैं. We can take tibia cut first and then we go back to that. So the tibial eminence is coming in the way. What we can do, we can take the tibial cut first and then we can go back to the femoral cut. Take the remaining cuts then. एक बार देख लो अगर होता है ठीक है, नहीं तो then we go do that way. हाँ. Go. ये तो हो चुका है. लेगा. Sure. So what we'll do, we'll take the tibial cut first now, because here the tibial eminence is coming in the way of the robotic burr. So we'll take the tibial cut, then it will be easier to take that cut. Tibia पे आ जाओ. Probe. Next पे आओ. Okay. Okay. Sure. So you can see that for the medial cut, it goes from front to back and then cuts it medial to lateral. But for the lateral cuts, it is coming from the anteromedial aspect and coming from anterior to posterior. So you don't have to basically retract the patella with the help of a Homan, because it is not coming in the way of the burr. Ashokam. So now we'll. Now it will be easier to take the femoral cut, remaining cut. Femur पे आ जाओ वापस. इसको हटाना. Suction. Okay. Chal. So we go back to the femoral cut now. Next cut.
Hello, Dr. Shekhar.
Yeah.
Can we see the monitor, please?
Monitor दिखा दो. Box. वो छोड़ दो box. हाँ. अच्छा.
Now, from the monitor, can you also see whether there is some remnant bone to be removed?
Okay. So can you see that? The
Dr. Shekhar,
yes.
you have decided on the sizing of the components?
Yes. So the size is E.
Okay.
If during the gap balancing there was less of flexion gap, maybe I could have downsized it. But then if we balanced it quite okay, so there was no need to change the size of the implant. And on the mediolateral aspect, we have already seen it on the screen on the laptop that the size was okay. So this is the box cut which we are taking, as we will be doing PS knee.
The size of the implant, the femoral implant, is decided on the CT planning. And if
Yes.
we want to change it, upsize, downsize it, we can do in the real time. Huh? CR we have not done. होगा क्यों नहीं?
So that completes all the cuts. Now we'll take off the robo.
मतलब मेरिल का implant। क्योंकि साइजिंग तो डिपेंड करेगा ना, साइजिंग लक्स होल। हाँ वही, तो सॉफ्टवेयर चेंज करना होगा।
इसको निकाल दो, नाइफ 1 hour। And can we have a
Here
clean
we can shift the femoral implant up, down, or proximally, distally, which we
Sheet,
cannot
sheet,
do in
clean
manual
sheet.
system.
pin remover?
Like in manual system, if you want to increase the flexion gap, then we have to do anti-referencing and downsizing in between size. But you cannot shift the implant as such up, down, or proximally, distally. Here you can do that.
Pin extractor, एक sheet, okay, okay, एक होमन,
ये जो है केवल सरफेस को देखो।
ये वाला नहीं, दूसरा होमन, yeah, okay, sharp होमन नहीं, so steam mop. Now, as we were mentioning, you can see artery. So there is this bone on the lateral aspect, and on the tibia you can see that there is this bone on the posterior aspect. These bones we have to remove by ourselves. Nibbler.
ଆପଣ ଆସନ୍ତୁ ଜଣକୁ ମୋମେଣ୍ଟ ଗୋଟେ ମୋମେଣ୍ଟ ଦିଆଯିବ Now we invite Saskar sir to give a memento to Dr. Divya Singh.
Okay. Central. Okay. what table का height नीचे जाएगा? ये ठीक है, इसमें यहाँ रख।
आगे जो आउट गाड़ी पीछे मोमेंट फैकल्टी को दे
Pin mop.
नष्ट करिया रोड
Okay. So that's what I wanted to show, that this much of bone is left behind posteriorly.
National faculty ସବୁ ହେଇଗଲା ତ ଅରୁଣ ଅରୁଣ ତୋର ତ ଟକ୍ ହେଇନି ମୋମେଣ୍ଟ ଦେ ହେଲା ନାଇଁ ନାଇଁ ହଁ ଚଲ ଏଇ ମୋମେଣ୍ଟ ଦିଅ Now we invite Dr. Arun Naik to receive a memento from Dr. Saskar. Awesome. बढ़िया से ये नालिया जिनस पिंचन तो लखा हो मु एपट दास सहित एपट है हो
theoretical chance is there this way that
Dr. Sujit Tripathi will receive the memento. Upon Saras.
Okay.
Dr. G.S. Patnaik to
हाँ हाँ उसमें करना पड़ेगा.
ठाकुर को दिया ही हाँ सकाळे आसतले बोधे ना नाही अक्षय तोर मोमेंट अक्षय एमती जी कलर फलर बाछिबु ना जोटा रैंडमली जाउची जो कलर है हां राज नहीं जा सारा से गोटे दियंतु अक्षय Paresh sir to felicitate Dr. Akshay Kumar Sahu.
इसको लगा रहेगा. You come to this side, ना? Lateral side. तू इधर आ जा. Osteotomy hammer. Osteotomy. Hammer osteotomy. Remove the posterior osteophytes. So there are posterior osteophytes present in the femur.
Dr. Devavarta Padhi. Yes.
Okay, Nibbler.
Vishnu Astra Vishnu Patra Vishnu Astra pra ଯାଇଥିବ କୋଉଠୁ विष्णु पात्र तो नहीं अक्षय को दिया सुजित को दियाला मनोज वाधवा को दिया अंकुर सौरभ दियाला विष्णु पात्र दिव्य सिंह दियाला संतोष कुमार को दिया रहा विप्लव दोलोई दियाला विजय कुमार को दियाला गाड़ी को दियाला अरुण नायक को दियाला संदीप सिंह से आसिले पाइबो सोम जाननी चिन्नी शेखर भाई
on the X-ray you can see that there was a one is spicule on the medial side.
दियाला कौन पढ़नी chairperson मानु को बेसो
You have to be very careful that you don't damage the medial MCL.
सस्कर भाई now अपन सर अंतु असंतु Dr. L.K. Biswal to be felicitated by the President of the Odisha Orthopedic Association, Sri Saskar Rao.
Correct.
All chairperson will get one. Upon the rest of the like, or a sir,
Group like those, no, other Russia,
ये काहू
Nibbler.
get करिवे संस्कार सर पुणी आउथर देबे आर के महापात्र सर आसंतु
मोठे दोज मोठे दोज रवेरो तो मार के दालो तो समस्त दउचंती let's take trial first and then we will decide about this defect. So no. Femur.
निर्मल सर तो ना निर्मल सर
Nine.
तन्मय सर नांती अतनु सर भी सकाळे आसले पळे गले सर पळे गले तांगा घरु
We have to do some videos.
तन्मय सर आज आसी परबेनी कहिजन कारण तांकर आज ये थिला किशोर आसी कि किशोर
रबे आपण पाखु पड़े
किशोर पड़ा
नहीं अभी अंदर हैमर
आई छी हां
लिफ्ट ऑफ
तो इधर उठी थी
पंच
femoral
femoral punch नहीं ये वो दो ना femoral का
ग्रीन कलर
हाँ हाँ मेरे इस वाला करना है टाइट है काफी
अच्छी रोदा
ग्रीन का बढ़िया
रेड देखबे
नहीं
ग्रीन दरकार
এটা সেটা জানো
कार ग्रीन अछि
नहीं ग्रीन
ग्रीन दरकार अच्छी सीधी आउट
preventing that
तो ना मेरा बहुत मेरा ये ब्लैक अच्छी
ऐसा तो ठीक है ना हाँ लेकिन अभी एक बार के लिए बैठा नहीं है ठीक से
ये मोटा अलग प्रकार ठीक है आउट नुआ फोटो उठे
नहीं सेटा को मु कैप्टन के नाल दे
अच्छा तो किस लगे
balance is fine everything is okay and there is equal tension in all the planes टोनी का टाइम कितना हो गया
एकू संदीप प्रेसिडेंट को दे दियो
okay so what we'll do
और
क्या बैलेंस
ओडिसा आर्थोप्लास्टी केस एबे बेस्ट निर्मल आपण ओडिसा से ए ओ ए गोटे आर्थ्रोस्कोपी आसु सेटा भी गोटे सेटा भी
hold handle just handle this
ओडिसा सेटा गोटे करते ना गोटे रहुनो निजे से माइक्रोफोन दे एठी आउ रोबोट एही का खांती माने बियॉन्ड आवर स्कोप
verify वो nibbler
Dr. Sekhar, Dr. Padi here.
yes
Please show the screen, how much balance and how
we'll
much.
just show you again trial tibial trial so till now we haven't done any soft tissue releases
Okay.
except for the initial medial release which we did
But
left.
posterior osteophytes you have removed, I believe.
yes that we have removed okay so you can see there focus on the joint. That's the mediolateral balance. Can you see that? इस पेस पे बिल्कुल यहाँ joint पे. Okay.
Yeah.
That's 30 degree. 90 degree.
But can we see the result on the screen also?
Yes, we'll show you. And this is the balance in the anteroposterior. Okay. Now, सामने सर जो टीबिया इसको थोड़ा घुमा दो ट्रैकर को towards tibia more बस ठीक है hold there. टीबिया मार्कर ठीक करो. Okay, capture. So that is showing the gap on the medial and lateral aspect.
Yes.
And if you sit down, there's a limb varus of around 3 degree.
Yeah.
Now we had planned a limb varus of 2 degree.
Can you go through the range of movement?
So this is in flexion. This is on extension. And this is the patellar tracking. यहाँ दिखा दो. But we are not done with the case now. Though it is balanced, but once I remove the tibial implant, you will see that there is a big defect there which we have to reconstruct. पकड़ना. Tibial handle. Stem आ गया. Femur extractor. Stem. Handle. Central here. Here another. Keep it there.
Effectively of the Bhubaneswar orthopedic law is a very important thing and for you so many things are covered. We are very thankful.
ये निकाल दो. ट्रैकर निकाल दो. हाँ. Nibbler. Okay.
मिस करिए
एक मिनट जो मैं डिफेक्ट दिखा दूं. एक Homan, one more. So you can see that there's a defect there. Can you see there? एक बेस प्लेट दिखा दो. ऑस्टियोटोम. So Dr. Padi, can you see the defect on the medial aspect?
Yes, yes. What you are planning for that?
So we'll just see how the tibial base plate is covering how the bone is covering the base plate, and then we'll decide. So I have got 90% coverage of the bone,
Yeah.
10% is left. I'm going to put 2 or 3 screws here and then fill that with defect. Okay, pins.
The posterior medial bone, you have to do a reduction osteotomy. I believe.
We will do a bit of reduction osteotomy and the remaining will manage with screws,
Yes.
cement and screw. Space. यहाँ डालो. हाँ. And one more here. Okay. Drill. So. Broach. Nibbler. Okay. Pin remove. Drill and screw. 3.5 के screw के लिए 2.5 drill bit. Screw दे दो. Implant open. Yes. Okay, next. उसमें नहीं आता. मेरे को छोड़. Leave it. Okay. Wash. निकाल. इस पिंस निकालने को दे दो. Wash. उसको रखना। Cement mix, yes. Common. Okay. Wash.
ଟକ୍ ଆରମ୍ଭ ହେଇଯିବ। ହଁ ମୋ ଅଛନ୍ତି ଅନ୍ୟମାନେ ଟକ୍ ଦବା ଅଛନ୍ତି ପିଲା ଅଛନ୍ତି। ଆଉ ତୁ କାହିଁ କହୁଛୁ କହିଲ ଏବେ ତ ସିମେଣ୍ଟିଂ ନର୍ମାଲ କଥା ଆଉ କଣ ନାଇଁ ଆମର କାହାର କାହାର ସବୁ ଆଉ ଟକ୍ ବାକି ଅଛି।
Okay. Now cement.
Dr. Shekhar,
Yes.
it was a nice demonstration. We are getting out of time, so
Yeah, that's
we are
okay.
planning to go ahead with our session.
Yes.
And
So-
your trial and balancing was very good and represented nicely as decided pre-operatively, and planning was done accordingly. So
Yes, so thing is that with so much of deformity and the defect also, we can manage with size 9 insert only, which is the smallest one.
okay,
We can move the femoral component up or
that shows
down.
that conservative bone cut with the robots.
Yeah. Thank you.
Thank you for the nice demonstration. Thank you, Sandeep.
Thank you. And
Sandeep.
at the same time, I would like to thank the organizers for inviting me here, and especially the
It was nice.
team here at Care Hospital. It's almost like my own hospital. That's the way I work at my hospital also, and I didn't had any trouble.
So after finishing, you come over to the
Yes, thank you. Thank you.
Suryan's Hotel.
बस ये हो जाए,
Thank
उसके
you.
बाद फिर ऑफ कर देंगे। ये सीमेंटिंग के बाद टूनिकेट ऑफ कर देंगे। कोई नहीं, जब तक वो हो रहा तब तक वो अपने आप कर लेंगे, वजह से भी उनका है ना।
Oh yes, yes, Dr. Soumya. Actually, I was working when the delay नहीं थे तो पहले. So we'll start the session now. Yeah. Okay. So please. So हमारा sequencer.
आर्टरी दे दो। हाँ, मस्किटो।
तो talk टा दे दे.
अभी कौन सा लगे देंगे आपको?
ए ठीक कंप्यूटर लगा दो. इधर बंद.
हाँ, 8646. यहाँ से नहीं
वहाँ नहीं निकालना। हाँ। Okay.
Now, after the wonderful live surgery session on robotic TKR, we are back to starting our. आगे कोई बच्चे?
Miller.
So,
Cement.
ready? Just hit the sound after. Oh, minus code. Huh. Oh. We invite Dr. Soumya Chakravarti to give his talk on periprosthetic fractures in TKR. Over to you.
Okay, femoral implant. Femur.
ଅରୁଣ କହିବ ଆଉ ଦିଟା ତ ହେଇଯାଇଛି ସନ୍ଦୀପ ସିଂ ଆସିଲେ କହିବେ ନା ସେଠି ଅଛନ୍ତି ନା
Implant. Yeah, sorry, impactor.
ଆସିଲା କହିବ
ट्रायल में भी ऐसा था थोड़ा सा डॉक्टर थोड़ा ज्यादा हो गया ना
Good afternoon, everyone. Thanks for inviting me as a faculty here. So today my talk is on periprosthetic fractures around total knee replacement. So I'll just discuss all the starting from the incidence and prevalence of the fracture. Periprosthetic fracture by definition, it's the area within.
Okay. Insert. Lift. एक बार और देख लेते हैं नहीं तो देंगे I'll try once more. Plus. ठीक है छोड़ दो Leave. Okay. एक बार देखें सीमेंट आर्टरी ठीक है Just don't hyperextend ना बस ये रहा हाँ देख लेते हैं एक बार छोड़ो लीव ठीक आ जाएगा वॉश एक काम करते हैं टूनिकेट ऑफ कर देते हैं है ना हाँ Section. Okay. नहीं देंगे मूवमेंट के लिए हाँ देते हैं Tenexa? हाँ Tenexa देते हैं। नहीं इंट्रावेनस just at the time of surgery तब देता। Vancomycin only if the patient is diabetic. Otherwise routinely नहीं। निकल हाँ निकल हाँ श्योर ओके ठीक है इसको थोड़ा सा ना पैक करके रख दे मस्कुलर है केवल ठीक हो जाएगा माप है ना हाँ थैंक इसको दो करके
टाइम मन रखुଛ कि କେତେ ହେଲା
बाकी तो स्टैंडर्ड प्रोटोकॉल है ना ये स्टैंडर्ड प्रोटोकॉल tomorrow you can make him walk and everything ना the effect is quite small so it won't matter yes sir if the stem was there then precautionary we could have put a stem otherwise also it's okay that's not sorry Okay. ठीक है ना?
अब नहीं लग रहा है सर, पहले लग रहा था।
ठीक है, हो जाएगा है ना? थैंक यू वेरी मच है ना सिस्टर, थैंक यू। ओके, थैंक यू। ओके, थैंक यू, थैंक यू, थैंक यू। Sir, thank you, sir. Thank you. Jerry. Yeah, get fish out of there. I would have to look at it.
The length of plate should be 2 to 3 times the length of the fracture. For transverse and short oblique fracture, it should be 8 to 10 times. And plate should aim for to cover the entire length of femur, and the overlap should be at least half the length of entire intermedullary implant. Short stem with multiple bicortical screws in diaphysis before it overlaps with the implanted stem. And if there is a long stem in situ, we can go for a monocortical screws, and we can also use the ensacclage wires, cables, and the locking attachment plates. So these are the just few X-rays to demonstrate the plating. So there's a very small option of external fixators also sometime. Only few small series are available till date. Elizarov, rail, or circular hexapod fixators are options. So there is very minimal soft tissue dissection, and we can achieve a reasonable alignment with that. And also we can go for early mobilization and weight bearing. So there's an option for